Okay, let's dive in. Training your technician. So I thought we could go through when I put this together. I was like, okay, like how did I actually train my technician who has turned out to be excellent? And these are sort of the four things I wanted to kind of discuss with you guys, and we'll go through. There'll be a slide on each one. So, and these are sort of goals that I had for my technician. I wanted her to be able to discuss the mechanism of action with her clients, our clients, answer questions, make recommendation of Shockwave. So if she's working with someone through like therapeutic exercise or massage, she knows when to say, hey, I think Shockwave would be a good modality for your dog. And then also just setting owners up for clear expectations during the visit and then after. So let's talk about all those. Okay, so for Dina and I, when I trained her, we had like 6 months together, and some of it was one-on-one, but it was a little bit didactic. So me like talking to her and then her answering or asking questions. And so this was sort of like a didactic piece. And what I wrote here on the slide is like what I really wanted her to have around as like walking around knowledge. So something that she can just, when owners ask, like, how does this work? What is this? She can say some form of what's on the slide. I want her to understand mechanotransduction and be able to describe it to an owner in a way that's like plain English and not doctor speak. And then what, like, how does that help us clinically? What tissues are actually healing? What is happening in the body? And I wanted her, this is not a full list, but this is like, here's my goal of like what you can say out loud without refreshing yourself. Um, and so when I taught her all this, I taught her more depth, but it was clear that like, hey, this is what I want you to be able to talk about: the cartilage healing, tendon, ligament, muscle, blood vessel development, stem cell recruitment, and then osteoblasts and how they're related to both bone healing and arthritis. Um, and so she might not talk to a client about all these things. She might say, hey, in your case, we're treating your dog for arthritis. So let's talk about stimulating the osteoblasts underneath that hyaline cartilage that will maintain cartilage health over the life of your dog. And we might not be talking about tendon and ligament or muscle healing in that particular owner. Some owners don't really want the detail. And so I have this like, I want her to always be able to say like Shockwave is stimulating the body's own healing mechanisms. We occasionally get owners that are like, I don't really care about the science, like give me the one liner. And so like I wanted to give her the words to be able to say this stuff confidently. All right. And I'm sure like if you're training someone, you have all the things you think are important. This was just my list in terms of being able to describe and teach what Shockwave does. Answering client questions. And I think in rehab, we get clients to do research online. And so there's a lot of confusion about the different kinds of Shockwave and does it require sedation? And I don't want to do Shockwave because I'm going to have to sedate my 15-year-old and all this stuff. And so I wanted Dina to be able to explain why someone might have some misinformation, what type of unit we have, and why we don't need sedation, and the difference between like a piezo and a hydroelectric, not scientifically, but like how it applies in clinic. It's not loud, it's not scary, it's not painful, and there's no sedation required. If I had to like rattle off the things that I wanted to make sure we conveyed to our owners when we're trying to offer the service to them. And then I sort of joke, I say this to owners when I say, hey, I think your dog's a good candidate for Shockwave. I usually say, this is not shock therapy. This is a high powered ultrasound. And I just like get that out of the way. And I wish you call it Shockwave, to be honest with you. Because people get confused and they're like, oh my God, I don't want to shock my dog. I'm like, no, it's ultrasound therapy. It's just a funny name. So anyway, and so I think when I thought about teaching Dina, I wanted her to be in the room feeling confident because she's not in the room with me. She runs her own appointments. She's by herself. So she needs to feel confident. She understands the modality. She understands the machine. She can answer a lot of the common questions we get when owners do research online. Okay, number 3, making the recommendation of Shockwave. So I wanted Dina to understand, like I said, she's working with a dog in a different capacity, to be able to say, you know what, we keep having I don't know, I'm gonna make this up. Breakthrough pain on your elbow arthritis dog. I think it's time that we do some ongoing shockwave for this patient. Let me explain to you how it works and why it will work for your patient. Um, so kind of the indications, I wanted her to have that as walking around knowledge, not every little thing, but the biggies. And so for me, the biggies is what I listed here. We do it a lot for OA, uh, joint disease that isn't OA. So that could be, gosh, I mean, that could be like the luxating hips that we did on Peaches, right? That could be any number of things. Any kind of soft tissue injury, we know Shockwave really shines there. Fracture healing, sometimes we forget about, but it's actually a great modality for that. And I do like a fracture healing section of my Shockwave when I'm doing post-op TPLOs. And so we do our
Mhm.
TPLOs a little different. We'll come in from the lateral side, so we're not trying to go through that bone plate. So we'll talk to owners about if we're doing Shockwave post TPLO, how we're sort of, I say, killing three birds with one stone, right? We're doing a preemptive OA treatment to protect cartilage. We're helping with that osteotomy site, and we're helping with soft tissue healing after a traumatic surgery. Um, and then, of course, wound healing and any kind of myofascial dysfunction, like a tendinopathy, psoas strain, that kind of thing. Um, I think we should also, our technicians who are delivering the treatment should know the difference between why we do more sessions during an initial shockwave series versus ongoing. We'll maybe do less. Uh, and we do some ongoing shockwave like you do, Cindy, where we just have somebody come in and we do it once a month or once every 3 weeks, um, or sometimes every other week because their body responds better to that. And that's usually after we've done like a series cadence every
Yep.
6 months, every 3 months, and then we're failing and having breakthrough clinical sign, then we'll try an ongoing. I have an LS dog with ongoing. He comes in every 4 weeks and he does best with that. We tend not to bring that up to owners first pass, but Dina obviously needs to know about that as an option if we're failing when we're doing our series, we're having that breakthrough. Um, and overall, our technician being able to make the recommendation, legally the prescription comes from the doctor. So uh, I think I wanted to just touch on that. So yes, I do make the official prescription for that, but sometimes Dina will come to me with a patient and say, hey, you know Rocco is having a bunch of elbow breakthrough pain. I think we need to do a series. And I'll say, awesome, I agree, let's do it. And so at first I guided Dina, and we'll get into the details of training on the actual patients in the next slide here, but uh, we sort of started with a little bit of an in-house protocol, and then she got really good at Shockwave, and so now she makes tweaks on the fly. Um, and so that's why I say, like, I make that initial Shockwave plan, and she makes adjustments to it in the heat of the appointment, and she's good enough to do that. And my goal was to get her good enough to do that, to be a decision maker in that patient's treatment plan. Okay, I lied. So we have one more. So what to expect? Um, I think your tech needs to be able to communicate that. So we talked about the fact that the shockwave benefit is often delayed, and so we want to just set owners up for that expectation so they're not disappointed that 2 days after their first shockwave session in a series of 5 were not resolved. Um, so we definitely talk about that on the front end so people aren't disappointed, and they know what to expect. And then we also describe just what a shockwave session looks like because some people still feel nervous after reading online. They can be loud and painful. We just sort of talk about dogs come in, they sit and they eat their snacks. It's all very low stress. And I put this picture. This is Foxy, and she's obviously having a pretty good time getting her. She loved her cervical shockwave, so that's an actual treatment that's actually not staged, but yeah, there she is. Okay, we're going to go into kind of the nitty gritty in a couple slides here, but I wanted to pause. You guys have any questions or comments on like kind of the outline of what we're trying to enable our tech with in terms of knowledge so far? Okay.
Sounds good to me.
Okay. We got to touch on safety. So like we do touch on like contraindications. Um, I put open growth plates with an asterisk because Peaches had open growth plates and I shockwave the heck out of her. And so to me, this is this is a theoretical risk that hasn't been proven that Shockwave will damage an open growth plate. And so when I'm making a decision, I just wanted to like mention this since I used her as a case example. When I'm like looking at a dog like Peaches, I weigh the pro and con. We have a theoretical risk that hasn't been proven, and then we have what I feel like I'm very confident in the benefit I'll get out of Shockwave. And so in Peaches' case, I felt like the benefit of the modality far outweighed the theoretical risk. And that was just my judgment. So that's why we moved forward and we didn't wait.
And I will add, according to the International Medical Shockwave Society in, I think it was 2023, they divided into high, medium, low energy, and you need high energy to affect growth plates. We don't have high energy, or we don't use high energy. So super safe. I agree. But
That's good to know.
always worth conversation with the owner. So.
Yep. Yep. And I've done that a bunch and I haven't seen any what appear to be negative effects secondary to that. Okay, so for the rest of this time, I wanted to talk about like specific Shockwave knowledge. Like, what do I need Dina to know in order to perform an excellent Shockwave session? And then the second part of this is like she has to be able to palpate the dog's body for accuracy. Otherwise, she cannot deliver a good treatment. So this is like two different buckets here, okay? And so we're going to talk about the, like specific Shockwave knowledge. And I put the stifle up here as an example. And what I did for her is for every body part that I felt like we were going to commonly treat, I came up with this. I don't want to use the word protocol. It's a jumping off point. It was a place for her to start. And so I picked a body part and I said, where are the areas of that we're going to focus on? So in the stifle, and this is like doctor dependent, right? And we use our judgment and we have what we like to do. And so this is just like what I like to do. I work on the patella and the patellar tendon. I work on the medial dish. And I made that term up. It's just the dish to the medial aspect of the patellar tendon where you can really drop that focal point of your standoff pad. You can kind of drop it into that medial aspect of the stifle and really scan and fan in there and hit your cruciate and hit your medial meniscus. So I just called that the medial dish. So she and I had language. And then, of course, the medial joint line. Those are my three places I really like to work. And so when I taught Dina general palpation, we really focused on these three areas when we palpated the stifle. She has to know how to find these areas. So it kind of brought my teaching her palpation into focus when we got down to kind of the nitty gritty. I gave her a jumping off point for dose, and I say these are averages. And so you can see I have a hash mark. So I like to do the layered approach. I usually have one standoff pad that I feel like is a little bit more important, and that's where the higher number is. So you can see this will come out to 4,500 pulses over an average stifle, and we still do about this. There are exceptions. If we have something unique going on in the stifle, or if we have a dog who has low tolerance, we'll drop our pulsed number down. I gave her an average for the standoff pads I like to use, an average span of intensity, and then I like to, for every body part, we talk about the sweet spots, so where we tend to get biofeedback. And this is just kind of what I find, and that's also why you'll notice those correspond with my focal areas, our sweet spots. As Dina has gained a level of confidence and experience, I will layer on another kind of layer of detail for certain body parts. The stifle is a really nice example because now if we have a dog that is a post-op TPLO is a little bit different than an arthritis stifle, which is a little bit different than a acute meniscal injury stifle. We have a little bit of variation in those three in our practice. I didn't teach her that until she was very confident with what you see on the page. I just felt like it was too much. And not all body parts have those tweaks, but and I'm always tweaking things. I still do some Shockwave, so I still tweak stuff and then I pass it to her. But I wouldn't have done that in the first 6 months she was working Shockwave. I just feel like that would have been overwhelming. I wanted to show kind of how we communicate with each other. So this is documentation. I can read and see, when a patient goes to her for Shockwave and then gets kicked back to me, I can see like what's actually been happening. So this is the piece of information I want to know. What session are we in our series? What number are we? What is our goal? So like I said, in the example, the stifle, our goals can be a little bit different. I like to know how deep into the series are we? Is this our first time? Is this our 10th time? We obviously have our body part and exactly what head we used, how many pulses, and what our intensity was. We talk about the areas scanned, which I can probably tell you that without reading what she writes, but sometimes we'll have a deviation for a reason. She'll say, gosh, on that iliopsoas, I was getting so much more feedback on the iliacus that I spent way more time there than up in the muscle belly psoas major. And so she might write that in there, that was like more emphasis there. Um, I always like to know biofeedback. So where do they get discomfort? And then any other notes, something, um, anything that would be helpful if, let's say, I need to do Shockwave the next time for this patient. So this is kind of our outline for how we communicate with each other. Okay, it's my favorite part. Okay, should I pause? Any questions or comments, you guys? No? Okay.
Nope, it's the anatomy. It's all about the anatomy. Sorry.
Yeah. Okay, so yes, and I agree with Cindy wholeheartedly that your shockwave treatment's only as good as the person operating it. And our piezo wave is so focused and so accurate. And that is a double-edged sword, because if you are good at palpation, you are going to hit the spot and do an awesome job. If you are not good at palpation, it's pretty easy to miss the mark. And so I was very particular with palpation. And for Dina, I taught her not just palpation of the body parts we're going to be shockwaving, but she needs to know how to do a myofascial exam. She sees patients without me, so the dog comes in, she has to do a myofascial exam on every patient. That is baseline. And so that's where we started. And we started with the bones, because a lot of our, what I call home base palpation points, are bony landmarks. So we took out our textbooks, we took out our skeletons, and we had live dogs. That's my dog in the photo. That's who we use most of the time because he's such a good boy. And we practiced palpating both in standing and side lying, and also partial side lying, all positions. And I just wrote out a list, and I was like, okay, these are the bony landmarks that you have to know. Some are directly related to our shockwave treatments. Some are not. Some are more related to our myofascial exam. And we practiced over and over and over again until Dina felt pretty comfortable. And then we went on to soft tissues. And so we had a lot of like free time together that we did this work out of appointments. She also did shadow a lot of appointments so she could get the flavor of what does appointment feel like start to finish, but we'll come back to that. But this type of training was really one-on-one in the room after hours. And then we do some tune-ups on patients later after she had this baseline. This took me a couple months to get her really good, because this is not an easy skill. And so, yeah, we started with joints, bones, and bony landmarks. The joints, I didn't teach her a lot of special tests, but we did palpate all the joints, feel joint lines, feel range of motion, what is normal, what is abnormal. Then we moved on to myofascial palpation, spent even more time here. Like I said, with bony landmarks, we focused on the soft tissues that are important for shockwave, but there were some extra ones that were important for our myofascial exam. I did not teach her everything in the body. I felt like it would have taken me forever to like do that. And so I gave her what I thought was a thorough, like intermediate level skill set. So we're not a beginner where we can't find anything. I didn't teach her everything I knew. I guess that's what I'm saying. We would have gotten bogged down in the details. So I tried to find a happy medium where I was teaching her enough to be excellent, but not too much. And now, Dina's been with me 2 years. Now I can like layer it on and be like, hey, let me show you this thing. And that's really fun. And I can like add. Cindy and I were talking before you guys logged on, and I didn't put this in here, and I wish I had. Um, but I teach an acupuncture certification course, and we teach palpation there too. And one of the things, and that's for doctors, and so one of the things I talk about there is when you like come in to touch a dog or any animal for that matter, coming in with a certain calmness and a certain energy about you will give you a lot of it'll give you you'll get more feedback, and you'll get more rapport with that dog, and then you will get more feedback from them, and then you will do a better treatment for them. So every time we palpate a patient, it should be a rapport building experience. And so I taught her, like, you come into the room, you lay your hand on the dog, you take a deep breath in and out, and you bring awareness into your hands. And it takes, it's awkward and cumbersome at first, but it can happen in a moment once you practice. So I'm like, before you palpate, I need you to breathe, I need you to touch, and I need you to bring your brain into your hands. And we just, every time we did palpation, we just like did that over and over and over. And it's really just attuning to your body and your patient's body so that you can get the information you need. So that is actually where we started. Then we started touching animals. Um, I talked a lot to her, and we did a lot of coaching on pressure, speed of palpation, and interpreting pain management signals from your patient so that you don't need to make them cry out, and that you don't need to lose rapport through your touch. So we talked a lot about having that style. Um, that's how I want my patients to feel safe, and I'm sure all of you do too, right? And so we talked. That was like threaded throughout everything we did for palpation. Um, and what we did, I can't remember this next slide. Um,
Yeah.
let's see. Yeah, we kind of talked about, where your patient is painful or weak. Um, I talked to Dean about like developing a pattern of palpation, and I showed her mine, but I'm not attached to how she does it. I just want her to find her way and do it her way. We talked about tissue texture, speed and pressure. So I mentioned speed and pressure, and I did a lot of demoing for her, like good, bad, try it a good way, try it a bad way. How does the dog react? Um, and then also tissue texture. So at first we were working on my young Labrador, and his tissue texture is pretty healthy, which is a great place to start. And then as she would sit in with appointments with me and shadow, I would say, oh, come feel this top band, come feel this trigger point, come feel this fasciculation. And so then we would start feeling and seeing the abnormal. Um, if I had a subtle sign of pain in a dog on my palpation, I would point it out to her. Hey, did you see that? Did you see the look to the side? Did you see them step away? Those kind of subtle things that take a little practice to recognize. And these are kind of the general body parts that I wanted her to know. She knew cervical, both front limbs, all down the back, and hind limbs. So that's kind of in my brain. That's how I organize things, and that's how I taught her. That was kind of our order. Um, this was sort of the putting it all together, where we worked on this simultaneously because we would do this one-on-one kind of clinicking time where we didn't have clients with us and we were using my dog. And we'd actually recruit friends who would drop off dogs for us as well, so we could feel different dog bodies. Um, and this was sort of the piece that Dina learned just sitting in on appointments with me. And I wanted her to just like hear how I communicated with patients. I wanted her to like steal words and verbiage that spoke to her about explaining things to clients. I wanted her to get like the general vibe, how we were professional and efficient, but we're calm and really kind, all wrapped up into one. And I think that the like calm and kind piece is challenging when you're first starting, because you're like so much in your brain. Oh, am I touching the right body part? Is this the right setting on the shockwave? Like, how's the dog doing? And we get really like tight, and we second guess ourselves. And so we talked a lot about like, more than the client in the room. This stuff. Let's just be calm. And if you feel like you're off, or you feel like this is challenging, that happens to me too. I and I feel like I've done this long enough. I can talk about that openly in front of some clients and say like, oh yeah, I don't know where I am right here, but I'm in the right zip code. So like, let me show you what it's like to have a hard one. We all have hard ones. Um, And we talked about the nitty-gritty, right? Like being on time, um, because we see back-to-back stuff, and like how do you structure your appointment so it feels really smooth and efficient, and you like walk away feeling like I did a really good job there. Um, Dina came from traditional GP, so we talked about how do you restrain a patient in a rehab environment, which is fear-free, volunteer restraining on their part, and all the little tricks to convince them that their therapy's awesome. And so we did talk a lot about that. And I mean, I demoed that a ton. So she like, stole all my tricks, which is great. Um, we also talked about, Dina was very, and I think most techs who are able to get this training are very committed to doing a good job. So at the beginning, Dina had some nervousness about being by herself. And I said, here's when you come get me out of my room and interrupt my appointment. Here's when you like come talk to me afterwards and ask me questions. Here's when you tell your client, I don't know the answer to that. Let me ask Wendy, she'll get back to you. And so we like kind of had a little bit of framework for that. And now that happens organically. And that helps me have a lot of trust in her. And she seems to always kind of know where we are on that continuum. And there's been a few dogs that are really struggling in their appointment, and she'll come get me and be like, you need to put hands on this dog today before they leave. And I'm like, awesome, great. And so just having that conversation, I think helped her feel like I had her back and she's not by herself. And it also helps me have confidence in her, right? That she's holding our patients and our care to a high standard.